Hi everyone, this is Professor Nicholson lecturing on Apply the Nursing Process to the Patient Receiving Anesthesia/Conscious Sedation. Please review the following subcompetencies on your own. An anesthesiologist is a physician with specialty training, and a certified registered nurse anesthetist is a registered nurse with advanced training and certification. The CRNA may work independently in some states, otherwise under supervision of an anesthesiologist. Responsibilities of anesthesia providers include determining the type of anesthesia necessary, administering medications, fluids, and blood products, managing the airway and oxygenation, as well as monitoring and maintaining fluid balance, vital signs, and cardiac functions while in the OR. So what determines the choice of anesthesia? It could be the procedure, how long it is, or where the location is, if it's an emergent or non-emergent situation, patient comorbidities, so having multiple medical diagnoses, the surgical preference, as well as the patient preference, with safety taken into high consideration, of course. Conscious sedation is a type of medication used to help a patient relax and feel sleepy during a procedure, but they stay awake and are able to respond. It helps reduce pain, anxiety, and discomfort without putting the patient completely to sleep. Short procedures that do not require anesthesia are typically done using conscious sedation. These short procedures include, but are not limited to, colonoscopies, seeing broken bones, cardiac catheterization, as well as cesarean sections. Characteristics of a patient during conscious sedation includes, but is not limited to, no pain or decreased pain. They are easily arousable. They respond to touch and verbal stimulation. They're able to follow commands. They have an intact gag reflex, spontaneous respirations, and dependent on the drugs used, may cause amnesia or sedation. Conscious sedation medications include a mixture of sedatives, anti-anxiety drugs, as well as opioids. They have a quick reversal and fast recovery time. The most common ones include benzodiazepines as well as opioid agonists. Midazolam, also known as Versed, is a controlled substance. It's a class 4, and it is very short-acting. Therapeutic class includes anti-anxiety as well as a sedative. The pharmacologic class is that it's a benzodiazepine. Therapeutic effects include reduction in anxiety, amnesia. This is a therapeutic effect because it helps the patient's emotional well-being by preventing distressing memories, and the other therapeutic effect is that it produces sedation. Adverse reactions to Versed include respiratory depression, drowsiness, as well as dizziness. Fentanyl, also known as Sublimize, is a controlled substance, Schedule 2, with a duration action of 30 minutes and very sedative and high doses. The therapeutic class includes that it's an opioid analgesic. The pharmacological class is that it's an opioid antagonist. The therapeutic effects include that it provides analgesia. Adverse reactions include respiratory depression or apnea, hypotension, oversedation, as well as arrhythmias. You need to know that naloxone, also known as Narcan, is used for the reversal. Nursing responsibilities before, during, and after administration of sedation are crucial for patient safety and effective care. Prior to administration, the nurse has several key responsibilities. They need to complete a thorough nursing history and physical exam. This helps identify any risk factors or contraindications. Nurses must also obtain baseline vital signs. These provide a reference point for monitoring changes during sedation. The nurse must also ensure the patient has adequate IV access. This is essential for administering medications and managing emergencies. All necessary equipment and emergency medications must also be prepared and ready for any unexpected situations. Remember, you always want to stay a few steps ahead and not a few steps behind. Lastly, you should provide patient teaching. Explain the purpose of the medications. Clarify that the patient will not be fully unconscious and let them know that some amnesia may occur during the procedure. The anesthesiologist or CRNA must also do this themselves as well, especially when obtaining consent. During administration, please keep in mind the anesthesiologist and or the CRNA is responsible for the patient during this time. There could be some instances where the nurse has some responsibility as well. So while sedation is being administered, the nurse must monitor vital signs closely, look for any deviations from the baseline as well. Anesthesia especially should keep an eye on the cardiac rhythm and perform a continuous ECG monitoring to help detect any arrhythmias early. Also, the patient's level of consciousness should be assessed continuously. This ensures the patient's safety and comfort throughout the procedure. After administration, nursing care focuses on recovery and safety. The anesthesiologist or CRNA usually reports off to the nurse at this time. The nurse should continue monitoring vital signs and the patient's level of consciousness. They should also observe for any delayed effects of sedation. Respiratory status should always be assessed and ensure the patient can cough and effectively take deep breaths during this time. The nurse should also check the patient's ability to tolerate oral fluids. This helps determine readiness for discharge or transfer. The nurse should also provide post-procedure teaching. The nurse should explain that the medication may take up to 24 hours to fully wear off, and the patient should be reminded about fall risks, advise against driving, and instruct them to avoid alcohol. Pulse check. What is most important for a nurse to assess post-operatively? The answer here is rate and depth of breathing. General anesthesia, in easy terms, is basically being put to sleep. It's used for emergencies, unstable patients, surgery that requires complete immobility and or skeletal muscle relaxation, as well as major surgery procedures with extreme tissue manipulation. General anesthesia is for lengthy procedures, as well as head, neck, chest, and most abdominal procedures. It requires airway management and ventilation by the anesthesiologist or CRNA. Characteristics of general anesthesia include a complete loss of sensation, no sensory perceptions, total analgesia, unconsciousness, loss of muscle tone and reflexes, loss of respiratory function, central nervous system depression, as well as amnesia. Phases of general anesthesia. Again, please keep in mind this is completed by an anesthesiologist and or CRNA. The first phase is induction. This is the initial administration of medication plus insertion of an airway device. The second phase is the maintenance phase. This is maintaining adequate anesthesia, perfusion, and ventilation during procedure. Last is the emergence phase. This is the discontinuation of medications followed by removal of airway management device. The patient at this point returns to their level of consciousness. General anesthesia, airway management. Once unconscious, airway management, control, and ventilation is required. The role of the anesthesia provider is to monitor ventilation, oxygenation, and vital signs during the procedure. Types of airway management include endotracheal intubation, which is when a tube is inserted through the mouth or nose into the trachea to maintain and open the airway. There's also the laryngeal mask airway. This is a supraglottic airway device that maintains an open airway, usually used for difficult intubations. And then you have your manual ventilation, which is usually with a bag and a mask. Endotracheal intubation must be done quickly, and it's very difficult. It protects the airway from aspiration. There are risks involved, which include trauma, so a sore throat is common for post-op patients. Inadvertent placement in the esophagus could also occur. Laryngospasms could occur, which is a sudden and/or involuntary spasm of the vocal cords that can temporarily block the airway as the vocal cords contract and close. And lastly, there's the risk of dental damage. Laryngeal mask airway is an alternative airway option when intubation is difficult. You need to know that this does not protect against aspiration, and you cannot use this with high ventilation pressures. Manual ventilation is assisting or taking over patients' breathing via bag valve mask or something similar as mentioned. It is not ideal for effective ventilation/oxygenation. It's important to watch for abdominal distension. This could indicate gastric insufflation with an aspiration risk, as well as compromised ventilation due to an elevated diaphragm that ultimately restricts the movement of lung expansion and could increase intrathoracic pressure. We will now discuss some medications used for general anesthesia. Propofol, also known as Diprivan, is an intravenous agent. It has a rapid onset and a rapid awakening after discontinuation of infusion. The therapeutic class is that it's a general anesthetic. The indication is for induction and maintenance of general anesthesia. Adverse reactions include CNS depression, bradycardia, bradypnea, apnea, hypotension, as well as myocardial depression. Now, let's say your patient is taking propofol, also known as Diprivan, and fentanyl, also known as Sublimase, as well as an antiemetic post-operatively. You would really want to monitor this patient for bradycardia. Nitrous oxide is a volatile agent. It's a liquid that vaporizes easily. It's also known as quote-unquote laughing gas and used commonly for dental surgeries. It requires more time to take effect than IV agents. You need to know that it relaxes smooth muscle as well as provides general anesthesia to patients. Common types include isoflurane, sevoflurane, as well as desflurane. The indication of use is that it is an induction and maintenance of general anesthesia. Adverse reactions include dizziness, nausea and vomiting, as well as headaches. Also note that it is used for pain control in labor and delivery. This can be given at the bedside as long as there is an order. Notice how only the patient is holding the mask against her face when using it. You will learn more about this in your next semester. Neuromuscular blocking drugs act on the cholinergic muscle receptors in the central nervous system. You need to know the therapeutic effect. It has total skeletal muscle paralysis. It paralyzes the structure in the throat to facilitate atraumatic intubation or for generalized paralysis needed for surgery or mechanical ventilation. You also need to know the common types. One is succinylcholine, which is a short-acting medication used primarily for intubation, as well as rocuronium, also called Zemuron. This is a longer-acting medication used primarily for mechanical ventilation, such as ICU patients. You should never use these medications without sedation. They only cause paralysis. They do not provide sedation or relief of pain and anxiety. Balanced anesthesia is the proactive of using combinations of different drug classes to provide optimal general anesthesia. I have provided a few examples on this slide. General anesthesia complications include excitement/delirium, malignant hyperthermia, aspiration, arrhythmias, as well as hypoventilation or inadequate oxygenation. You need to know the priority nursing assessment during the first hour after general anesthesia is oxygen saturation. We're going to dive deeper into some of those general anesthesia complications. First, we'll start with excitement/delirium. This occurs during induction and emergence of volatile agents used for general anesthesia. Signs and symptoms include involuntary movements, laryngospasms, vomiting, as well as sensitivity to external stimulation. Nursing implications include reducing noise and stimulation, preventing injury, as well as airway safety. Malignant hyperthermia is a rare life-threatening complication of general anesthesia. It causes a rapid, uncontrolled increase in muscle metabolism, leading to dangerously high body temperature as well as muscle rigidity. It usually occurs in the OR, but patients are at risk for up to 12 hours following general anesthesia. It is most commonly associated with an inherited genetic mutation, but that's not the only aspect of its cause. For example, volatile inhalation anesthetics could be a trigger. Serious complications of malignant hyperthermia include, but are not limited to, circulatory failure as well as kidney failure and cardiac arrest. You need to understand that malignant hyperthermia is an emergency. Signs and symptoms include tachycardia, decreased oxygen saturation, increased end-tidal CO2, which means there is a higher than normal amount of carbon dioxide in the patient's exhaled breath at the end of expiration. Other signs and symptoms include muscle rigidity, diaphoresis, as well as fever, which is usually the late sign. Treatment includes stopping surgery if possible, discontinuing the triggering agent, so the anesthetics, administering the antidote, which is dantrolene sodium, which must always be in the OR tackle box at all times. Treatment also includes supportive care, such as hyperventilation, oxygenation, and a cooling blanket, as well as extra close monitoring. The last general anesthesia complication we're going to touch on is aspiration. This is the inhalation of fluids or solids into the lungs. It's caused by a loss of a gag reflex as a result of general anesthesia. This can be life-threatening and it can lead to pneumonia or respiratory distress. So how do we prevent it? Ensure your patient has had nothing by mouth prior to surgery. Also, ensure your patient has received antacids prior to surgery. This is usually ordered by the surgeon. Lastly, ensure that the patient is getting ET intubation if able to. Remember, ET intubation protects the airway from aspiration, unlike others. General anesthesia risk factors include complications associated with age, so older adults and children are at more risk, respiratory disease, cardiac disease, renal disease, liver disease, presence of gastric contents, family history of malignant hyperthermia, as well as illicit drug use. Pulse check. List out medications an unconscious person receives during surgery. Hopefully at this point you paused and thought this out. General anesthesia makes someone unconscious during surgery. Examples include propofol, succinylcholine, and balanced anesthesia. What are the others we just went over in this lecture? Please list out and familiarize yourself with these types. Go back if you need to. Local anesthesia is a type of anesthesia that numbs a specific area of the body, allowing a patient to remain awake. It works by blocking nerve signals. You have topical anesthesia that is applied to skin or mucous membranes. It's available over the counter or prescribed. It's used for pain control, not surgery. You also have injected anesthesia. This is an injection of local anesthetic into the skin or mucous membranes that inhibits peripheral nerve conduction at a localized site. It has a rapid onset and 1 to 3 hours in duration. It's used for suturing, dental procedures, as well as small incisions. Lidocaine is an example of a local anesthetic. The therapeutic class is local anesthetic. It produces loss of sensation and possibly loss of motor function along specific nerve pathways. It does not alter level of consciousness. Regional anesthesia is a local anesthesia injected into the area immediately surrounding a nerve or group of nerves. It disrupts nerve transmission, causing loss of sensation, numbness, and sometimes loss of movement depending on dose. It does not affect respiratory or cardiac function. It is used for, which is what you need to know, surgery on extremities or the abdomen, as well as in obstetrics. In obstetrics, this often involves spinal or epidural blocks. This can also be employed during cesarean sections. A peripheral nerve block is a type of regional anesthetic. What makes it so specific is that it's a local anesthetic injected along the pathway of a specific nerve. Typically, ultrasound guidance is used. It produces loss of sensation. Common types are shoulder blocks for arm surgery. This is done prior to the OR and sometimes used in conjunction with a sedative. It wears off slowly. As mentioned, epidural and spinal are types of regional anesthetics. Both involved injection of local anesthetic through the spaces between the vertebrae and the back. Both provide anesthesia below the level of the injection. The patient is awake and conscious. Know that both could affect respiratory systems due to the anesthetic agent's impact on the central nervous systems and muscles involved in breathing. An epidural is a type of regional anesthesia only inserted by an anesthesia provider. It's a large diameter needle inserted into the space between the ligament and the dura without puncturing the dura. If the dura is punctured, there is a high risk for a spinal headache. A catheter is threaded into the epidural space, similar in appearance to a peripheral IV, but much bigger. This setup allows for continuous or intermittent infusions of local anesthetic, making it suitable for variable length procedures or for laboring patients. The epidural can also be used to administer analgesics postoperatively. For example, a dose of narcotic may be given at the end of the procedure before the catheter is removed. Also, alternatively, the catheter may remain in place to allow for continuous administration of pain medication after surgery. A spinal is also a type of regional anesthetic. It's a small diameter needle inserted between the vertebrae through the dura and into the spinal space. This is the subarachnoid space, where the cerebral spinal fluid is. A local anesthetic is injected all at once and then the needle is entirely removed. Time is limited for the duration of action. You need to know that the most important assessment within the first hour after surgery, specific to a spinal anesthesia, is to assess for the return of sensation to the lower extremities. To provide further clarity on the location of an epidural versus a spinal anesthetic, you need to know that an epidural requires a catheter that remains in place, while a spinal does not. You need to know the proper position for regional anesthesia administration, specifically related to epidurals and spinals. You will see in this picture here, the patient is positioned lying down on their side or sitting up. Notice the curvature of the spine. I always tell my patients, think of a mad cat or an angry shrimp. Regional anesthesia complications. You need to know that hypotension is very common initially. Typically, right after the procedure, a patient may experience a sudden drop in their blood pressure. Other complications include incomplete blocks, high block, which affects their respiratory system, medication toxicity, damage to spinal cord or nerves, an epidural hematoma, which is a collection of blood outside the dura mater. This is the outermost membrane surrounding the spinal cord in this case. This could compress the spinal cord, leading to potential neurological deficits that require prompt treatment. Lastly, a postdural puncture headache, as I mentioned briefly earlier. This is also called a spinal headache, as I said. This will be discussed more on the next slide. As you've probably figured out, you need to know what a postdural puncture headache is. The headache is caused by the leakage of cerebral spinal fluid. This causes a decrease in the cerebral spinal fluid volume in the spinal column and surrounding the brain. The headache is usually positional, worsening when upright and improving when lying down. An epidural blood patch is a medical procedure that treats postdural puncture headaches, or spinal headaches as I keep referring to. Typically, this is done by anesthesia. They insert a needle into the epidural space. Then once the needle is in place, blood is drawn through the IV catheter and slowly injected into the epidural space. The injection may cause a sensation of pressure or cramping in the back. Please review this slide regarding the signs and symptoms as well as the treatments. Regional anesthesia nursing implications involves careful patient preparation, education, as well as vigilant monitoring during and after the procedure. Please review this slide carefully on your own. And be sure you should always ensure and document that the epidural catheter was removed and intact. If it is not documented, you did not see it and it did not happen. Pulse check. What are some advantages of epidural anesthesia compared to general anesthesia? I recommend comparing and contrasting all the different types of anesthesia. The answer to this pulse check is reduced pulmonary complications, less risk for aspiration, and the fact the patient is awake. For instance, during a C-section, it makes it a greater experience for the parents. Of course, keeping safety in mind.